Thank you. Thank you everyone for coming. What I'll be talking about today is a professional practice transition program for the advanced practice registered nurse. This is actually what my capstone project was for my DNP program at Texas Tech. Wait, turn it on and it might work. There we go. I do want to just a disclaimer out there. When I was working on this capstone project at the time, the name of the organization I was with was Physician Network Services. That name has now changed to UMC Physicians. UMC Physician currently has over 130 providers now, but the ratio of physicians to nurse practitioners is still the same as the time of the project. And as of right now, UMC Physician has about 40 different clinics and specialty areas as compared to 30 when I started this project. As I said, at the time of the project, there was Physician Network Services. They had over 30 acute care, primary care, and specialty clinics and services within the Lubbock area. There was over 80 nurse practitioners and physician assistants, with the nurse practitioners being 61 to 20. There were 20 to 25 physicians employed at any given time. This was the status of this organization of June 2014. Historically, though, UMC Physicians, they had a very sporadic orientation process for new NPs and PAs, if any at all. Many times when I was working out in a Shalwar clinic, someone would come up to me, smile, and I would say, "How are you? Who are you?" And they would tell me they were a new hire and they were told to come out to my clinic, and many times I would not be informed of that. So very sporadic. Maybe they had a day or two of training, and then they were sent out to wherever clinic that they were hired for. So I saw this as a problem, and I sent out a confidential needs assessment to the current NPs and PAs. I inquired about any issues that occurred during their first few months of employment. I sent out 79 surveys. I got a 13 return, so 16.9 return rate. 6 respondents identified themselves as NPs, 2 as PAs, and 5 did not list their title. I did find out later that I spoke to about 15 different NPs and PAs that said they never checked their work email, so they would have responded if they checked their work email. But I did identify some themes from the survey: communication, knowledge, support, discouragement or frustration, and problems not fixed in a timely manner. So the problem I identified, there was no mentor program or transition program in place to assist NPs and PAs with acclimation to their new position. The new NPs and PAs, and when I say new, I was focused at that time on brand new graduates, okay? They were at varying degrees of competency. There was insufficient guidance and support for these providers. That can cause job dissatisfaction, job turnover, lower productivity, and ultimately the worst thing, it can lead to poor patient outcomes. Many of these new hires were placed in very busy clinics. They were encouraged and pushed to see a massive number of patients, especially during flu season, and so it was sometimes scary what could possibly happen with these patients if they were not cared for properly. So all participants of the needs assessment supported development of a specific orientation and mentor program for this organization. So I wanted to clarify that, so the majority of providers at UMC Physicians at the time of this project start, and also now, are nurse practitioners. I really think it should be called UMC Nurse Practitioners, but I didn't get a vote on the name. Definitely more NPs are hired versus PAs. At the time when I started this program, a PA had not been hired in 2 to 3 years. That's just how it was. And they hired many new NPs, and again, when I say new NPs, I'm talking new graduates. They put them in the float pool, okay? So you could be going to internal medicine, you could be going to an urgent care, you could be going to a specialty clinic, and these are brand new, so I thought that may not have been the best thing for them. So I wanted the development of the professional practice transition program, it was focused more towards the NPs in the float pool, but I did make it available to PAs too, if they wanted to participate. So, what was the significance in this? When you have a new NP transitioning, you go from an expert RN position to a brand new novice NP position, and that can be very overwhelming and daunting. So then you have a new position, you're in a novice position, and you don't have sufficient guidance. And so I believe that you're being set up to fail in many situations. Maybe not intentionally, but it can be set up to fail. And time again, nurse practitioners are shown to provide quality health care at lower cost and produce greater patient satisfaction. So we have this great quality item there, if you want to say it that way, and yet we're setting up people to fail. So I feel like that needed to be addressed. So a professional practice transition program, it supports the growth of the NPs. I focused on the Institute of Healthcare Improvement, or the IHI Triple Aim objective, which we want to increase population health, increase the patient experience, a positive patient experience, I must say, and decrease per capita cost. Well, studies have shown NPs are shown to improve patient outcomes. NPs are associated with increased patient satisfaction, and they're shown to provide quality health care at lower cost. So we're meeting all of this with a nurse practitioner provider. When I looked at the literature, what I found was that there aren't very many transitional programs out there, mentorships, residency programs for nurse practitioners. But what I did find was that there was some literature that showed the transition into a new NP role is very challenging and overwhelming. There's concern for lack of infrastructure to support the NP role, especially those NPs that are placed in rural clinics. They may not have someone they can actually physically touch. They have to rely on telephone or computer calls. And you have multiple external and internal stressors for the new NP, personal and professional life balance. Many times you go, I know I went from a 12-hour shift in the hospital into 8 to 5, which sounds great, but I had to rearrange children, and I put a lot of expectations on myself that were not realistic. The clinic I was at sometimes put unrealistic expectations. You need to see 40, 50, 60 a day. You can't do that. In isolation, you feel like you're on your own at times. I found a lot of literature that supported mentoring. It's shown to have positive impact on job satisfaction, prevent less job burnout, and they're shown to decrease job turnover. Looking at financial journals, time and time again, it showed that turnover costs businesses approximately 20% of an employee's salary to replace that employee. When you go through the whole orientation process and trying to teach them, and you're seeing less patients, and then after 3 months, that nurse practitioner said, I'm done, I'm leaving, so then you have to start all over again. So, I mean, if we want to just, if you look at a $100,000 salary, that's $20,000 that you've just flushed down the drain. So why not put that money into investing into a mentorship program to help keep those nurse practitioners? So my aim when I did this project was to implement a professional practice transition program in an ambulatory healthcare organization. And I wanted specific orientation and mentorship components to develop more competent nurse practitioners, and ultimately just to deliver quality healthcare to patient populations of varying degrees. This was a program implementation. I found that the needs assessment demonstrated the lack of support and direction for new providers, and a program was needed. So I did get verbal support and support letter from the executives. Confidentiality was maintained from initial needs assessments. The respondents could identify themselves as an NP or PA, but I did not ask any other identifying factors. I used Benner's framework. I reread her book. I think I read it once when I was in my BSN program, and I reread it again, and it made just more sense. She states every time a nurse transitions into a new role, that nurse starts out at the novice level. That makes sense. And I love this statement: a newly acquired advanced degree does not automatically make the nurse practitioner an expert. Okay? Because once again, we start out as RN experts and we're feeling good. And this is what I teach my students all the time. You're here, you come into nurse practitioner school, and then you become a new NP student. And at the end, then you become an expert NP student. But then guess what? You go get hired in your new job, you're right back there. Okay? And that's what we have to keep telling ourselves. And so with this program, I feel like I could gather the new NPs. After they completed the program, they would be in this area here, but then I would give them the tools to progress to that proficient and expert levels. So the purpose was just to establish a specific orientation process for providers and incorporate a mentorship relationship. Several things that we talked about: orient the nurse practitioner. I was surprised to know that a lot of them had never even toured the place they were going to work until the first day, and they were like, here, go see 30 patients, okay? Acquaint them. Hey, let's go meet everybody. Let's go meet the people that are behind the emails that you'll see, okay? Provide direction to obtain appropriate licensure. I know in my schooling, if I was taught this, I don't remember, but when I graduated, I had no idea how to obtain my APRN license, and I had to have that first before I could, and then I had to get a DPS first, and then a DEA. And just those steps that seem simple, but when you're just already overwhelmed and someone's coming at you saying, how come you haven't had this license yet? It'd be nice for someone to say, you know, here's the step-by-step process. EHR, we all love it. You know, there's a hard orientation to that. Meaningful use. We hear these words over and over. A lot of us know it's something out there that we have to meet, but maybe we're not quite sure why. And we have some people coming by every few months telling us we're at this percentage and we need to be at this percentage. But I thought, hey, it might be useful to understand what they're talking about. RVUs. This is a word I had never heard of until I got hired, and they start dangling this magical term called an RVU. If you meet this RVU number, you're going to make all this money, you know, all this bonus money. And okay, so what is that? How do you get it? Is that really worth it? You know, I mean, there's so many different things that go along with that. Appropriate coding and billing. Again, I didn't feel like I got a whole lot of this instruction in my schooling. I know I had been practicing for a year and a half when they finally told me, hey, there is a difference between preventative visits and problem visits. There's a different code out there. And I was shocked and, you know, appalled, and they said, oh, don't worry, we've just been changing your codes. Well, if you would tell me, I would change it, you know. Scope of practice, and then of course, having an NP with a trusted mentor. How beneficial is it just to be able to know that you can call someone, text someone, meet someone for coffee, just to go over your day and ask for input and advice. So I wanted them to do a program survey. The survey I actually used was the Meisner Nurse Practitioner Job Satisfaction Scale. Introduction of mentor and mentee. Stage 2 was orientation with 2 phases. Phase 1 was just the general new employee orientation, and then we would have an orientation specific for the nurse practitioners. Stage 3 would be development of the mentorship relationship, preceptorship, and then the post-program survey. I did obtain permission to use the survey from Deanna Cox. She is she developed this scale. Sorry, that's not very clear for you guys. Okay. So then here came my problems. So I wanted to start this in the fall of 2014, but unfortunately no new hires took place from October 2014 to January 2015. After January 2015, they did have new hires, but there was a lot of barriers because every new provider they hired came from out of state, and they were having issues with transferring their license to Texas. And unfortunately, we had a catastrophic event within the UMC physicians. Dr. Rice passed away. He had a very large practice. And so in the month of February 2015, there was a hold on hiring of new NPs because they weren't quite sure what they were going to do with his massive practice, which had about 14 to 15 nurse practitioners and PAs. So here I was sitting there wondering what to do. And I thought, okay, what else can we do at this? So I looked at other employees to pilot program or even parts of a program. I found out that there was an NP and PA that had experience but was relatively new to UMC physicians, and their managers felt like they weren't quite getting it, is what I was told. So I spent some time with them, and I reviewed components of the orientation process, such as coding and billing, RVUs. I gave feedback and answered questions regarding patient care, and I really did receive favorable review from the NP and PA that I worked with for about 2 months. I worked with them. But once I was doing this and other NPs were listening to what I was saying, and they heard me talk about coding and billing and RVUs, and they said, you know what, we've never been taught on that properly either. So, and many of these were very seasoned, and they voiced interest in reviewing the program content. I've had several, though. I had a folder, and several people asked me for copies of my folder just to review it. So I discovered there were new providers to UMC physicians. They had the professional experience, but they were new to their current role. Some of these saying that they had been in a diabetes specialty clinics, and then they went to internal medicine or vice versa. So they were in a novice role. And then I had nurse practitioners coming up to me saying, hey, we want a voice in this organization. There's a lot of us in here, but we don't have a voice. So I discussed with the executives to establish an MP committee. I even went to a board meeting. I found out, though, in the state of Texas, since UMC Physician is a nonprofit organization, in the state of Texas, you can only have physicians as your officers of the board. That's in the Texas Medical Association rules and guidelines. I did, though, say I did want a committee. We can include PAs as well, but just to have a voice. At UMC Physician, as like other places, they collectively call MPs and PAs mid-levels, which I don't particularly like that word, but I feel like, I say, well, give us a voice. We definitely provide most of the patient care for all the patients, so we need a voice. And that was met with mixed comments. So I had some physicians and executives that were for it. They did ultimately tell me that they were going to put it on hold because at that time we had the CEO going out and a new CEO coming in. So, but I did get some things accomplished. Licensing and credentialing, because I went around to every department and I talked to every department. I said, how can we make this better for MPs? And I found out with licensing and credentialing, they were giving the new MPs a pack, a 20 to 40 page pack, and having them write out all their information, and then someone would take that pack and put it in the computer, and it took hours. So then they've decided, talking to me, let's just send the new MP electronically that pack, so they can put it in and we can bypass someone just sitting there. So I thought that was an achievement for that department. In the EHR training, they were having the new MPs come and sit for 8 to 12 hours at a time listening, talking about how to do an EHR. I got them to split that up. So they do a few hours, learn how to do a note, go out and see what your patient population will be. Then you can do what they call macros, pre-completed notes, based on what population, then go back and relearn some things that you missed. So and that went over really well. So I feel like the initial focus of this program was too narrow. The needs of providers were varied, and I believe healthcare organizations must provide support for all providers at all stages to promote growth. In this one, I'm actually using this right now. Review of coding and billing would be beneficial in MP's school curriculum. I probably should state that as a more extensive review of coding and billing would be beneficial. And so I am going over that with my students right now in our roles class. We actually learn on coding and billing. So we continued with the first implementation of the program for new hires in May 2015. It was going well. Though I did switch jobs and I came over to LCU. So it's been kind of, from what I understand, hasn't been really carried over very well. They still send people to me working my 1 day a week to try to help out. I suggested we analyze the new MPs and PAs productivity 3 to 6 months after completion, compare it to those that have not gone through a program. Is there a difference in revenue? Because I met a lot of resistance because of cost. How much is this going to cost? We got to pay someone to be a mentor, and then we have to pay someone to, follow someone around. But I felt like if we could have this to show that we can see more patients, we have better coding and billing, that could be a big difference. I wanted to create a modified program for NPs and PAs with previous experience but are in new roles at UMC physicians. And I also suggested we do intermittent reviews and topics, kind of like maybe something like this, just every once a quarter, send out a flyer to everyone saying, hey guys, we're going to talk about coding and billing. We will talk about RVUs, what they are, if you guys want to come and you can review those things. So, recommendations for future. I feel like transitional programs and or mentor programs, that they should be incorporated in any kind of, in everywhere, into any healthcare organization for nurse practitioners. The ANCC, they have recently developed, they were in the early stages of developing this when I was doing this project, but they do have a practice transition accreditation program in place for APRNs. And I just looked at their website and they had a handful of APRN programs. Most of their programs are for RN residency in the hospital, but they do have that in place. I feel like more research is needed to compare programs that are in place for nurse practitioners to assess for monetary gains. And when I talk about monetary gains, it might be because maybe they're more efficient in coding, they get more reimbursement, maybe they're more effective in seeing patients, so it's more effective for the corporation. Most importantly though, patient outcomes. If we can effectively see our patients, we're going to have better outcomes and personal satisfaction for the nurse practitioner. And I wanted us to kind of talk about this, and I put this a question mark. Residency programs for nurse practitioners. I don't know if you guys understand the differences in nurse practitioner status across this country. There are only 21 states, including Washington, D.C., correct me if I'm wrong, Doctor, okay, that allow what we call full practice nurse authority. In Texas, we are one of the most restrictive states, meaning we have to have a supervising physician to oversee us. We have to have set meetings with this particular physician to make sure that we're not doing anything dangerous or whatever. But if we are allowed to operate at our full scope of practice, we would provide more health care to underserved communities, and it would just be a great thing. But so if we were to become unified across this country as all nurse practitioners having unified full practice authority, would a residency program be beneficial? Would it be accepted? Would it be wanted? And so I think it'd be a good thing, but after Dr. Hatch's response, I'd kind of like to get your guys' input on that. So, okay, that's it. Leave that up, or? Okay.
Nice job.
So, very grateful to have Dr. Bolyard here at LCU and working with us. She's obviously a very excellent faculty member and is in touch with the needs of most of the nurse practitioner students. There's some things that I wanted to build upon, which I thought her project was excellent. This is a very timely project, a very interesting project. So to put this in perspective for you, I want you to visualize this as I describe this to you. You just graduated, you're starting your first job, you're already struggling with some self-doubt, you have fear of misdiagnosing a patient, fear of lawsuit, losing your license, fear of harming a patient, you're feeling pressure from extensive financial investment. You need to make up financially for all the education you put in to get there. You need to perform financially to assure your new job position is solid. Lack of acceptance is a concern also from your peers when you get there, your new job. There's ambiguity from your peers. They don't care whether or not you're there. You're just filling a role that they don't have to fill. Expectation of working 60-hour work week, struggles with patient acceptance in your role. They have a difficult time transitioning from your role as an RN to a nurse practitioner. You have patients with complex illnesses, multiple comorbidities. You have a new EMR system to learn, and you need good patient documentation to protect yourself. There's expectations for seeing patients every 15 minutes in your practice. There's no other NP to collaborate with when you get there. The physician maybe that you're collaborating with maybe not physically available to you, or maybe on site, but is busy with a full load of patients himself, and probably in a nonverbal way may communicate that only come to me if you really need something urgent. What would your anxiety level be with a job like that or a situation like that?
Now it's really high.
It's really high. And a lot of people are thrown into those situations without adequate mentorship or without adequate orientation. I can tell you from personal experience, I would like to think of myself as a seasoned nurse practitioner, and transitioning to a different job even after 10 years of practice and being thrown into a brand new location, learning a new EMR system, different patient load, it was very nerve-wracking. And the whole idea behind the education the nurse practitioner receives is really to prepare them for a base level entry into practice. If they don't have someone that takes that and continues to nurture their growth and continue to help them through their practice acclimation, they're not going to do well. And what I hate to see is a lot of people are starting to flee their first jobs because of those concerns. They have struggles when they're in their first jobs. There's actually an article that I pulled that was pretty interesting, and it was done in 2010 by Canadian family physicians, and they interviewed 23 new nurse practitioner graduates, and out of those 23 nurse practitioner graduate students, about a third of them left their first job because of all those concerns that I had mentioned before. There is, a serious problem with people going from the registered nurse position into the NP role, and people not understanding that that's a significant role change for them. Most of the nurses in our programs or in the NP programs are pretty strong. They have a very strong drive. They have a no-quit personality. They have high academic performance. They have a lot of good nursing experience they bring to the role. But those characteristics will help some of them survive when they're thrown in the deep end. But a lot of them will not feel any job satisfaction or enjoy what they're doing, or even will begin questioning why they began to change from the RN to the NP role. So it's so important that we really do nurture that. There's an article in 2015 by AANP that did an integrated literature review just on retention and transition of roles. And what they found was the overwhelming conclusion of these articles they reviewed showed that if there's a nurturing environment and they invest in the growth, a measured progressive growth of the NP graduate, that they'll continue to retain their employment there, and they'll have high satisfaction and enjoyment of their job, plus their performance will improve. If that's not nurtured, most of these nurse practitioners leave to go to their positions and don't stay where they're at. Okay, so Dr. Bolyard mentioned residency programs. And most residency programs are about a year in length. They're after your education and your training. They're additional clinical training for your ability to perform your job appropriately, and even for physicians for board certification, most of them have to go through residency as well. So it's a standard for physicians right now, and it's funded federally. Most of the time, Medicare, Medicaid, VA, all of them fund residency programs for physicians. There is no funding for nurse practitioners of any kind, and that, in my opinion, needs to change on a legislative field. It would be really interesting to see if a 1-year residency following the NP program would increase the satisfaction overall and transition into that role. I think it would. Most of the nurse practitioner programs, you're getting clinical time through the entire program, and you're getting exposure, but it's totally different when you're just on your own and you don't have your preceptor with you anymore. It would be so nice to have, instead of attending physician, you would have a mentor, a seasoned nurse practitioner that you would report to or work with for that first year of practice. So, I'd like to hear some viewpoints, and Veronica, you're in our program now. Would you be, I mean, tell me what you think about residency programs, that whole idea. Would you be willing to move to do
I
1 year
found
residency?
it's really interesting that for this topic today, because just yesterday and today, I've been having some email correspondence with, I was approached from a very rural community, 2,000 people, pretty small, Memphis, Texas, you may know where that is. I had to look it up. And the nurse practitioner in that clinic, the only clinic in that town and the only on-site provider, and she wants to retire. And she owns the practice and wants to sell the practice. And I said, whoa, that would be way too much. You know, I'm not ready for anything like that. And so part of the email conversation I had with her was possibly some clinical rotations there to even see if it was an ideal place. Second was an internship / residency, 1 to 2 years prior to her deciding to leave the practice. So I had that discussion, emails, and I haven't got a response back, but because I feel like the need right now is in the rural settings, but I am not comfortable. I mean, I feel like I'm a very good student. I've been a nurse for 20 years. I have a lot of experience, but I think that when I get into that role, I'm a novice, and so I need some guidance and direction and someone, you know, to bounce things off of, and not maybe long distance over a telephone call. So I think a residency program would be great, and myself, I would of course be willing to move. So, but I don't know that that is, you know, in the cards for everyone in my position.
Yeah.
I do think it would be very beneficial. We do get a lot of clinical rotation, but it's very guided type, and I think
It's safe.
It is safe.
I know it's scary when we come visit you, but it's safe because if you were to make a wrong choice,
they're going to correct you.
yes. But when you're on your own, you're on your own.
It's your license and it's
Yes.
your livelihood.
Yes.
And the fear for me, there's a significant amount of fear that, you know, they're placing. I mean, I know we don't have full practice authority yet, but the need for that is there. You know, I mean, we definitely need full practice authority, but we are somewhat limited in what we can offer and what we can do. So there's a fine line you have to walk.
I know it's not real popular. There's a very big push. You know, everyone wants to be independent. I understand that. But I really think the safe thing would be, just from my experience and also working with students, maybe say you can apply for independent practice after X amount of years of practicing. But not go straight out of school and be totally independent. Or if you want to become independent, you must complete a 12-month residency of some kind.
And I think that would definitely meet my expectations before I was independent.
Are you aware of any of these 21 states that allow independent status? Are there any residency programs to help these new graduates transition?
There are not that I'm aware of. The only one, I came across a grant that was provided to Rochester University, Department of Family Medicine, for $1.6 million to fund a 5-year residency program for NPs there. And they're still in the development phase of that. I'm not aware of a formal residency program. And let me define this for you too. A residency program pays the person who's training. So the resident is paid. So it's supposed to help you in meeting your needs, so it's not a burden for you to do your residency. It's not, usually you don't make $1 million doing it, but you can pay your bills, you can eat, and you can drive a car to where you need to go. And so, you know, to find that funding is always difficult. And certainly I think there's still some pushback from medicine and some other people that are needing those funds to expand their programs and also find places for their residents and things like that. But we have such a huge responsibility, and I think some really incredibly talented and intelligent individuals that are NPs, but we just need to be sure that we are able to access adequate training and mentorship in order to be successful. And so I know that fear is there. I've talked to many preceptors who have said that probably the number one thing that they notice from students is that there's fear of being wrong or fear of making a mistake. And that's understandable. You're in here to help people, and that'd be the worst case scenario is you harm somebody. But
And I think from my experience, it's been, I'm not reckless in any sense of the fashion, but while I'm in training, now is the time for me to be aggressive and say, this is what I want to do and this is how I want to treat this patient, because there is someone there to correct me.
Yeah.
I mean, you can't be afraid right now, because if you're afraid right now.
right.
It's also I know the very first patient I saw myself, I was confident as a student, I was getting diagnosis, I was treating those tough patients. My very first patient all by myself was allergic rhinitis, aka runny nose. And I nearly panicked trying to figure out what nasal spray to give them. You know, I was a mess because I thought, oh my goodness, it's now up to me, you know, and now I kind of laugh about it and I giggle and I give that example, you know, to my students. But it's overwhelming, you know, this anxiety that you can experience as a brand new baby nurse practitioner. So I just believe that we have to have something in place.
It's about confidence. You have the knowledge. It's just having the comfort level, knowing there's somebody over there that I can ask if I feel uncomfortable with something, or they could be a second pair of eyes, or give me some advice. And you may not even need to use them. That's the funny thing is you know, just knowing they're across the hall or down the way may be enough for you to feel confident enough that you don't second guess every move that you're doing. But going back to just even the orientation or mentorship at your job individually by the institution, I think that's a really important thing that the institution should invest in, that you're going to go work for, or the organization you're going to work for. Number one, they want to retain you, I would expect. They don't want to invest in training you and the time it takes to get you oriented. Well, it's not even orientation, or get you into the job and then you just leave because you're disgruntled or upset or stressed out. The other thing too is I would imagine that they would draw in more patients if you stay longer, develop those relationships, and you're confident and people like you and you do well in your job. And then lastly, I would imagine that just the fact that the providers would probably interact more easily together, collaborate together more easily if they knew what they were, you know, what was going on, and there was definition of their role. I can, you know, the thing with the paying for a mentor or a teacher or instructor or anything like that, what I would probably say is, we're not going to pay you, but we'll reduce your load that's expected by half so that you can adequately train this individual. That alone, I would think that'd be enough compensation for most people to say, yeah, that sounds reasonable, so I can actually not kill myself. I'm actually taking on another burden. So there's probably ways around that in some way, but there needs to be a formal orientation for sure.
I had just two more things. Are you aware of attrition rates of new grads of NP programs when you did your research, thinking that what you would implement would help with attrition rates? Is there a 20%, 15, 10?
I couldn't find any. Did you come across any at all?
From the programs or from their jobs?
From their jobs.
Just that one I quoted, 1/3 were gone. After
1/3, I
June.
missed that. The other thing is we heard Andrew Cates, the attorney for Texas Nurses Association, present last week. Your idea is a road to independent practice, to approach the Texas Medical Board with some type of plan such as that. I know you're both active with the South Plains Association for Nurse Practitioners. Have you guys approached Andrew, and are you talking to him as we approach the legislative session about that might be something that would be amenable to the Texas Medical Board?
Sure.
A road to independent practice, maybe not fresh out of nurse practitioner school, but like you said, a year out.
Mm-hmm.
Then you can apply for independent status. That seems so much more, that seems reasonable.
Yeah, already our collaborating agreements are like that, where the longer you have experience with the physician who you're collaborating with, the less time you have to meet with them, or the less frequency you have to have meetings with them for quality assurance. So I think it's already kind of moving in that direction, but to answer your question, on an individual basis, I don't meet with those people, but we have paid lobbyists, and we also have people that are heads of organizations that go to those state legislative meetings and actually meet with them.
I haven't heard any plans like that. From what I have heard and seen, is like our main push is just showing all the research that shows that nurse practitioners are quality healthcare providers. We are able to go out, we can meet, Texas itself is so underserved, and you have these providers that can go out, that we're restricted in a lot of ways. But, I think maybe throwing, saying, because I don't know of any medical student right after graduating from medical school that would be completely competent to go out. They go through a residency.
Mm-hmm.
Now, on the flip side of that, I know when I was going through this program, I had some people approach me saying, be careful what you say, because if you say that nurse practitioners need a residency or need this program, then you're just supporting the medical association, saying that you guys aren't competent.
Mm-hmm.
And then I thought, well, but you guys go through, the physicians go through a residency. That's just, it's expected.
I think it just is an enhancement.
I think it's more of a want than a need
Yeah.
for most of us.
Well, competency is not the only issue.
Right.
You mentioned many of the other issues. The time management of moving through multiple patients. Think of flu season, when
Yeah.
75 people show up at your clinic.
Right.
So it's not just a competency issue.
Sure.
It's other issues. It's shifting children. It's adjusting to your
Yes.
different schedule from school to being
Yes.
a nurse practitioner. So that's, they might want to target competency as the issue. Oh, you need a residency program, but it's not just a competency issue.
It's just a growth in the whole role, and it's just learning, how to just pick up on cues with your patients. Like now, I can just watching a patient walk into a clinic, I can already tell you 15 different things about him. But when I was brand new, I was just, I was waiting for him just to come talk to me, But yeah, and you're like, oh my goodness, what did I miss? What did I miss? But you can just pick up on things, and it's just because it's growth in your role. It's just a maturity, other than
I'm
everything
so
else.
surprised at places that don't have any really formal orientation. They would hire a new grad, and then they may have a day that they say is orientation, but one day is really not adequate. And then they will say, well, here's your regular schedule. And they don't even modify their schedule. They don't ramp them up slowly as they gain more confidence. They may be the sole provider even by themselves. It's concerning. So there's ways for improvement for sure. It's just a matter of getting administration of these organizations on board. And then, starting just with something small like orientation, and then building on that, having set mentors that are educated to be a mentor, that know how to properly mentor a student, and do that on a regular basis. That would be great to set up an organization. And then even beyond that, the educational system, if we could set up a residency program, I think that would be an amazing asset of some kind. The problem with matching and residencies and all that, it's very complex, and it would be something you would have to do in multiple places and have partners in that, and have to have the funding. It would be a very complex thing, but it'd be nice to get the ball rolling with that for sure.
It's already difficult to find just preceptors.
Yeah, exactly.
That are willing to train students, so.
Yeah.
Is that because they feel it's a burden, or like the ones I've seen, it's like they actually use the one, especially in the rural areas.
Yeah.
They come in, they're like, I need a hand, and you're working beside them as well as I'm taking a little bit of this load off of you, where some it feels like, oh, I'm having to train this person and tell them everything, so it's more of a.
Well, like I mentioned, there's a big, even more so than when I first started, there's a big push for volume. And they want to see a certain number of patients per day, and they have that undertone of, I've got to do this, or, I'm going to get in trouble with the boss, or am I going to meet my goal or my objective? And so they're worried that it'll slow them down. But also, some people are just not comfortable teaching others. That they know it well themselves, but they can't communicate it well to a student, or they don't really have the skills to do that, or they've never been formally trained and they don't feel comfortable. So there's a lot, it's kind of a multifaceted problem on why some people don't want to do that. But it is a challenge for sure.
It also depends on the stage of your student. A brand new nurse practitioner student is brand new, but when you have some at Veronica's stage, she would be a help. But a year ago, she might have, slowed me down. So, but volume is big too. That RVU I was talking about. A lot of places are hiring, giving them lower base salaries, but saying,
if you meet this RVU bonus, wow, how much money are you gonna make? But in order to achieve that, you're gonna have to see a lot of patients, so.
You know, another idea would be maybe an organization saying, if we put you through a 6-month even residency or something like that, where we pay you, but to do it, and your expectation is we don't care what your load is, we'll do like 10 patients a day, something like that, and you'll have a set mentor that you can work with. But if you agree, if we do that, will you agree to work for us for 3 years? I think that's a reasonable thing you would consider. Maybe some trade-off in that way, just saying, okay, we really want to retain you, so we expect if we're going to do this, you will stay here with us.
I think that would be reasonable,
Mhm.
a contract. I mean, we do that for lots of different things as nurses.
Sure. But I think, Veronica, for your situation, I think you're smart. And I would certainly, that would be part of the negotiation process. I would say, I'm very interested in rural medicine, but I also very cognizant of where my boundaries are. And I would like to start with some sort of internship, residency, something like that, until I get comfortable with it. We can keep going. So, well, thank you all very much.
Thank
Appreciate it.
you. Very good.